Hi, class. We are about to dive into chapter 8. So we're putting our bones together now and making what we call articulations or joints. Let me switch to screen sharing mode, pull up my PowerPoint here, and there we go. So this is chapter 8. We're looking at joints, which are more officially called articulations. This is where two or more bones meet. The joints aren't always movable though. So in some cases, you might not even realize that what we're looking at as a joint is not in fact or is in fact a joint. You wouldn't recognize it as being two bones going together. So typically, joints will allow mobility while preserving bone strength. So instead of your bones bending, it's the two bones together that are causing that motion. And the amount of movement is determined by the structure of the joint. So we're going to look at how joints are structured and classified and put together and held together. Typically, joints are categorized by their range of motion or their structural organization. So let's click on this. There we go. Let's talk about the functional classification of joints. I'm going to pull out my notes while I'm thinking about it because I may have some extra things to maybe draw on my whiteboard. I remember having some. Kind of flip through those as I'm talking. So the functional classification of joints, there's my dog. The synarthrosis. A synarthrosis is an immovable joint. So there's no movement. That prefix syn, S-Y-N, is referring to, really, please stop, is referring to the fact that there's no movement in the joint, and arthrosis is the joint. So without movement or without a joint. These are extremely strong because there is a trade-off in anatomy world between movement or range of motion and strength. So in other words, the stronger the joint, the less movable it is. The more movable the joint, the less stable it is. Something like your shoulder joint. It's your most movable joint in your whole body. You can go all different directions with it, right? That is a very unstable joint. It's very easy to damage your shoulder. And if you've ever known someone to have a shoulder injury, it can take years and years till that shoulder is back to normal. Something like the sutures in your brain or sutures in your skull, those obviously are immovable and they're very strong joints. So again, there's this trade-off between movement and strength. So that's a synarthrosis, immovable. An amphiarthrosis is a kind of sort of movable joint. So this is where there's a little bit more movement allowed. Stronger than a diarthrosis. A diarthrosis is a freely movable joint. Typically in an amphiarthrosis, you have articulating bones that are connected by collagen fibers as well as cartilage. So let's keep on moving and shaking through this. The structural classifications of joints. So those are the functional classifications. They can be synarthrosis, amphiarthrosis, or diarthrosis. Now we're going to look at how they're structured, how they're put together. They could be a fibrous joint. Fibrous joints are held together by fibrous connective tissue. This would be like a suture. A suture is a synarthrosis. This is, again, the sutures in our skull. Think about that. And so there's dense fibrous connective tissue holding everything together. There could also be a gomphosis. Gomphosis are our teeth joints. All of our teeth held into our maxillary or mandible bones. That makes up a gomphosis. Again, they're held in by fibrous connective tissue. In the case of the gomphosis, it's the periodontal ligament, and that's the structural classification. I thought I had some drawings for these. Maybe I don't. All right. Sorry about that. Then we have another example of a fibrous joint is called a syndesmosis. A syndesmosis is an amphiarthrotic joint. So it's slightly movable, and this is where the bones are connected by a ligament. The example here would be the distal end of the tibia and fibula. So down by the ankle, where the tibia and fibula are held together, it's slightly movable, not immovable like a suture or gomphosis, slightly movable, and there are ligaments holding those bones together. Our joints can also be cartilaginous. So we had fibrous, and now we're adding cartilaginous. Cartilaginous joints are held together by cartilage. A synchondrosis is another synarthrotic joint, and this is formed from the cartilaginous bridge between articulating bones. So this would be like the ribs and the sternum. Where our ribs come in and connect with the sternum, there's cartilage there. It's slightly movable because that allows for respiration to occur. It allows for our thoracic cavity to expand and contract. So it's called a synchondrosis. Then we have a symphysis. A symphysis is another amphiarthrotic joint, and there's a fibrocartilage pad in between the articulating bones. The big example here is the joint between the two pubic bones. On the anterior side of the two pubic bones, the pubis bones come together, and there's a pad of fibrocartilage right in between them. It's called the pubic symphysis. The pubic symphysis is a fibrocartilage pad between the two pubis bones. So again, amphiarthrotic. So we had fibrous, cartilaginous, and now we have bony joints. A bony joint would be like a synostosis. A synostosis, it's hard to say, is another synarthrotic joint. So there's no movement associated with it. And this is when your bones fuse. So if you remember how bones grow, you have the diaphysis and then the epiphyses on either end, right? And then that metaphysis in the middle, that growth plate, or the epiphyseal line. Well, that is a synostosis. It's a joint between those two parts of the bone that were growing together. So those are our structural classifications. We also have synovial joints. Synovial joints are diarthrotic. These have a huge range of motion. This is probably what you think of when you think of a joint or an articulation. Very wide range of motion. This is at the ends of our long bones. Fingers, arms, legs, etc. So, again, functional classifications are synarthrosis, can be fibrous, cartilaginous, or bony. Amphiarthrosis can be fibrous and cartilaginous, and diarthroses are classified as synovial. So we have all of these structural classifications: fibrous like sutures and gomphoses, cartilaginous like a synchondrosis, bony which would be a synostosis, fibrous the syndesmosis, cartilaginous a symphysis, and synovial. There's a lot of S words in this chapter, as you see just by looking at this page. So what I suggest doing is writing each of these names on a note card or even on a post-it, and see if you can recreate this chart as a graphic organizer. At the top of your graphic organizer, you would have functional and structural classifications of joints, and then you would have your three functional categories, and then off of your three functional categories, you would have your structural categories beneath it. Mix them up. On the other side of the note card, have the examples, right? And that way, you can do it either way, with the examples or with the S words, as we call them. And that way, you can rearrange them on your floor, on your table. If it's a post-it, you can even stick it to your wall. Play around with it. Get to learn these words. So, pause the video here. Go back and review. Keep on moving and shaking. Synovial joints. There are several parts of a synovial joint because synovial joints are highly movable. There are lots of things involved in them to keep them stable and protect them. One is articular cartilage. We mentioned articular cartilage briefly in the last chapter. It's basically the slick, smooth covering on the ends of our bones. The cartilages at the ends of each bone is also separated from each other by a thin area of synovial fluid. The synovial fluid and the articular cartilage are there to reduce the friction between bones. So it's basically a very watery matrix compared to other cartilages, which means there's not as many chondrocytes there, which means there's not a lot of area for growth and repair, which means if you damage your joints, they're very hard to repair. This is, arthritis. This is osteoarthritis. As you get older, as your bones begin to wear and tear, it kind of is what it is. That just happens with normal wear and tear of the aging process. We'll talk about that later. So along with the articular cartilage, we also have the joint capsule or the articular capsule. This is basically a sac that encloses the ends of the bones themselves. So imagine the two bones coming together, and then around that area is basically a little bubble that holds the fluid. The ends of the bones are covered with the articular cartilage. It has an outer fibrous layer, an inner synovial membrane, and there's accessory structures in there like tendons and ligaments. And this joint capsule is continuous with the periosteum of the bone. So it's like the periosteum of the bone just continues around the joint capsule, and that space is filled with that synovial fluid. So there's also a synovial membrane. That's the inner lining of the joint capsule. So the outer lining is fibrous with the continuous with the periosteum, inner lining synovial, secreting the synovial fluid to lubricate the joint cavity, cushion, protect, prevent abrasion, and as well as to support the chondrocytes that are there to provide them nutrients and so on and so forth. The quantity of synovial fluid is less than 3 milliliters, so it's a very small quantity of synovial fluid within these joint capsules. So there you see what I mean. You can see this outer fibrous layer coming from the periosteum, and then the inner synovial layer, the fluids in between, articular cartilage is at the end of the bones. So let's talk about the synovial fluid. It's very clear. It's viscous, so it's kind of thick. It has a consistency of like a raw egg white. And that's because there's hyaluronic acid in it. And that hyaluronic acid is there to, again, protect and defend invaders and bacteria from that area. It's basically produced by the synovial membrane, so that lining itself is secreting synovial fluid. It's circulating from the areolar tissue, and it percolates through the articular cartilage, provides oxygen and nutrients to the chondrocytes, as well as carries away metabolic wastes. Overall functions: lubrication, nutrient distribution, and shock absorption. So it's lubricating by providing that cushioning, it's circulating the nutrients and getting rid of the waste products through an exchange process, and like all liquids, it can absorb shock. The viscosity increases with increasing pressure. So depending on the joint and your kind of overall fitness level, that synovial fluid can be changed in composition to be stronger and absorb more shock. If you are doing something that requires more jarring, weight-bearing exercises and stuff on your body, your joints will respond to that. So, functions of synovial fluid. Let's keep on going on. Let's talk specifically about the knee. There are several accessory structures that are related to the knee joint. So they provide stability for our knees. The tendon of the quadriceps muscle is not actually a part of the knee joint. It helps to limit the range of motion and provides mechanical support. There's also bursa. Bursa are thin, fluid-filled little pockets. I like to think of them as bubble wrap. They're like little pieces of bubble wrap going around tendons or ligaments so that they don't rub against each other. Picture like a violin string, right? And if you've ever paid attention to violinists, their bows, those little hairs from the bow kind of fall off over time and break over time with that rubbing. And so the bursa, imagine a bursa is this little bubble wrap going around the bow, not allowing that friction to break the horsehairs of the bow. And that's exactly what a bursa does. It prevents the tendons and ligaments from rubbing against each other, reducing friction and acting as a shock absorber. There's also fat pads. These are just masses of adipose tissue. They're, within that synovial cavity. They're within that synovial membrane. They're usually just outside of the joint capsule. Again, they're for cushioning, but right next to that synovial membrane, protecting the articular cartilage. It basically just fills the empty spaces. In the knee joint specifically, there's also a meniscus or articular disc. This is a fibrocartilage pad. It's not a fat pad. It's fibrocartilage, and it's between the bones. It can subdivide the synovial cavity. It can also help direct the synovial fluid flow, and there could be variations in shape of the fibrocartilage because it basically fits like a puzzle piece between the bones. Along with the knee, we again had the bursa, the meniscus, the fat pads. We also have accessory ligaments. So we talked about the quadriceps tendon as not being a part of our knee joint, but we do have other accessory ligaments. We have capsular ligaments or intrinsic ligaments. These are just little tiny ligaments within the joint capsule. Then you have extrinsic ligaments. These separate, or these are separate from the joint capsule. Extracapsular and intracapsular ligaments. You have the patellar ligament, which is outside of the joint capsule, and then you have the cruciate ligaments, which are inside the joint capsule. So let's see, this is a good sagittal section here of the knee joint. You can see our quadriceps tendon, and then here you have our patellar ligament holding the patella in place, a bursa, more bursa. Again, look at where the bursa are. They're basically those little pieces of bubble wrap wrapping around the ligaments, making sure that they're not rubbing against each other. Inside the joint capsule are the cruciate ligaments. Outside the joint capsule, is it labeled? I always try to follow the labels on these. Well, you see the patellar ligament there. You can see the meniscus. Again, it fits like a puzzle piece in between the tibia and the femur. Remember, the fibula does not articulate at this joint. The fibula just articulates with the tibia at both proximal and distal ends. It's pretty much all you see on this one. In your lab practical 2 review sheet, there's a few detailed diagrams of the knee joint. All of those structures that are labeled on there, you'll be responsible for knowing in lab as well as in lecture. So that's kind of your study guide for the knee. So let's talk about synovial joints in general. As I mentioned before, greater range of motion results in a weaker joint. Synarthroses are the strongest, diarthroses are the weakest. Dislocations, also called luxations, this is when you go beyond the normal range of motion and the articulating surfaces are kind of knocked out of whack, they're out of position. This could cause damage to the joint structures. It could be very painful. The pain is from the nerves in the joint capsule. There's no actual pain receptors in the joint itself, but the joint capsule has nerve receptors associated with it. You can pause the video here, go back and answer these questions. Let's talk about the general types of movement. There could be a gliding movement. Gliding is a linear motion, kind of like a sliding, where one surface is gliding on a relatively flat surface of another bone. Angular motion, where you have 2 axes that are moving on one plane. This could also be like a change in angle. Circumduction, which is more of an angular movement, where the proximal end of the bone is fixed and the distal end moves in a path, kind of drawing a circle. And then rotation, which is where you're going around a longitudinal axis, rotating. This is just showing you the different movements, and we can classify our joints based on those movements, like a gliding joint, for instance, the clavicle and manubrium. Those 2 surfaces are fairly flat and they can glide against each other. If you fall, that clavicle and sternum can kind of move just a little bit to help absorb that shock. Some other examples are the sacroiliac joints on the back of the pelvis. Very good example of a gliding joint. Hinge joint, that's just open and closing. Your knee joint, your elbow joint, your ankle joints, your interphalangeal joints, these are all hinges. A pivot joint would be like this. And you also have one here on the proximal side of your radius and ulna. And a condylar joint, these are like your carpal joints, your metacarpal and your metatarsal joints. All of those little bones in your hands and feet all just kind of glide around each other a little bit, and that's why you can smush your hand up or expand your hand up. That's those bones kind of gliding and crunching against each other. A saddle joint is this is the only saddle joint in the body. It's just between the trapezium and the metacarpal bone of the thumb. A good ball and socket would be your shoulder and hip joints. They fit together like a ball and a socket. You can pause the video here, go back and answer these 3 questions. Let's talk about range of motion and movements. We're going to do some activities with this in lab. But just so you know, flexion extension, that's pretty easy. Flexion is moving or decreasing the angle of the joint with the body. So when you're flexing your arm, you're moving your hands towards your shoulders. Extension is the opposite. You're increasing the angle of the joint. When you're in anatomical position, you're in extension. Everything's extended. Your legs, your arms, your head, your back, etc. Hyperextension is then when you go beyond anatomical position. So like doing some type of like Superman where you're pushing your arms backwards and sticking your chest forward. That is hyperextension. Sticking your neck back, hyperextension. This lady is nice enough to demonstrate all of these movements for us. Flexion, extension. Flexion, you're bringing everything in. Extension, you're pushing it all back. So, and these are animations that are not linked to the PowerPoint, but if you look on the Mastering A&P website, they're all there for you, just demonstrating flexions, extensions, etc. Lateral flexion is when you're bending from side to side. Dorsi and plantar flexion are only referring to the foot. Dorsiflexion is when you're pointing your foot up, toes towards the sky. Plantar flexion is when you're pointing so that you're standing on your tiptoes. Lateral flexion, dorsiplantar, video that you can look on masteringamp.com. Abduction and adduction. Abduction is when you're decreasing the angle between the body and that, I guess, body part. You can do it with your hands, you can do it with your arms, you can do it with your legs, right? Adduction is when you're bringing it in. Adduction is when you're bringing it away. You're adding to your body when you bring your, when you adduct your arms and legs. You're adding it back. There's adduction and abduction, and there's the video that's not linked. And you can do it with your wrists, your fingers, etc. Circumduction is moving a body part while the proximal end stays in one position. So this is like moving your shoulder. Oh, did you hear it crack? Moving your, there it goes again. Moving your shoulder around its joint. I can only do it with one side. There you go, circumduction. There's the video that's not linked, but you can look at it on masteringamp.com. There's some questions. You can pause the video, go back and answer. Let's talk about rotation. Rotation can be described as right or left. Usually, we're referring to medial or lateral if we're talking about a limb. So you can medially rotate at your shoulder or laterally rotate at your shoulder. This is just rotating inward or outward. And right and left rotation would be like when you're referring to your head or your trunk. You can also do pronation and supination. Those are special forms of rotation that are only dealing with the, well, kind of weird, only dealing with the radius and ulna when your radial head pronates or supinates. Supinate is palm up, pronate is palm down. There we go. Video that's not linked, another video that's not linked. Other special movements. Opposition is when you move your thumb into the palm of your hand. Eversion, inversion is just referring to your foot, either moving your foot inward or outward. Opposition, inversion, eversion. Video that's not linked. Protraction and retraction. Protraction when you're bringing something forward. Retraction when you're bringing it back. Depression, or when you're like shrugging your shoulders. Elevation is moving something up, like closing your mouth or raising your shoulders. That's elevating. Protraction and retraction, depression, elevation. Pause the video, go back and answer these 3 questions. Now we're going to go into some specific joints. So these are the outcomes for this new little section. You can see them in your chapter guides. So let's talk about joints of the appendicular skeleton. They typically have a huge range of motion. Again, weaker than the axillary joints because they have a bigger range of motion. Sternoclavicular joint and sacroiliac joint are joints of the axial skeleton that are very strong. So here are some of those joints listed for you. Joints of the axial skeleton are very strong. They have very limited movement. The atlanto-occipital joint, atlanto-axial joint, again, limiting range of motion. There they are. You can pause the video, go back and answer these questions. Let's talk about vertebral articulations. These are between superior and inferior articular processes of the vertebrae. They're a gliding diarthritic joint, so they do permit flexion and rotation. They are between the adjacent vertebral bodies as well. So the vertebrae, and I wish I had some, I might. in my closet back there. I'm not even gonna bother. We'll just pretend. So we'll pretend that this is a vertebrae and this is a vertebrae. So they articulate here on their articular processes, and they also articulate here with the vertebral bodies. Of course, there's a pad in between, but they articulate like this, kind of, sort of, right? Except it's not crooked because I can't get my hands to be flat like that. So the superior and inferior articular processes are a gliding joint for flexion and rotation. The vertebral bodies are separated by that fibrocartilage pad, also called an intervertebral disc. So they're symphysial joints. So the vertebral column is also stabilized by several ligaments. Let's talk about those intervertebral discs first. With increasing age, their water content in them decreases, so they slowly begin to smush, and you will actually lose height because they're not as puffed up and fluffy. They're made of two main parts. One's called the annulus fibrosus. That's the tough outer ring of fibrocartilage, collagen fibers attach it to the vertebrae. Inside of the intervertebral disc is a soft gelatinous core called the nucleus pulposus. This gives the disc the ability to absorb the shock. There you see it. So our main vertebral ligaments, one of my favorite ligaments in the body, ligamentum flavum. Sounds fun. Basically connecting what's called the laminae of the adjacent vertebrae. You'll see it in the picture. Then there's a posterior longitudinal ligament and an interspinous ligament. They're pretty much all named after, and this is true for ligaments, they're pretty much all named after either what they're connecting, so once you know the bones, you can figure that out, or they're also named after where they are. Posterior longitudinal ligament. It goes longitudinal on the back side. They're really not that tricky. Supraspinous ligament connects the spinous process from the sacrum to C7, so it's just all the way up. Anterior longitudinal ligament on the front side, longitudinal. Here you see them. This is pretty much the same picture I think that's in your lab practical guide. So you can see your anterior and your posterior longitudinal ligaments here, the interspinous in between those spinous processes, the supraspinous above the spinous processes, the ligamentum flavum connecting on that back of those transverse processes, and nucleus pulposus, annulus fibrosus. That's it. Super straightforward. Let's talk about some issues with intervertebral disc. You can have a bulging disc or herniated disc. A bulging disc would be from a weakened posterior longitudinal ligament, which is then going to allow for the compression of the nucleus pulposus, and then the annulus fibrosus gets distorted. And so that tough outer layer starts to bulge. A herniated disc is when the nucleus pulposus breaks through the annulus fibrosus and goes into the vertebral canal, compresses the spinal nerves. Much more painful. There you see a normal and a bulging. Here you see a herniated. This is when that, again, nucleus pulposus is coming out and just pinching that nerve right there. Not a fun thing to live through. Let's talk about changes that occur in our bones. You have osteopenia. Osteopenia is just the overall general term for lack of ossification. So this is going to happen in all of us. It occurs starting at age 30. That's most of us, right? And continues on through life. It's more severe in women than in men because of hormone issues. Osteoporosis is when you're actually losing bone and it's affecting your function. So osteoporosis is like extreme osteopenia. Loss of bone mass, reduced cushioning, that's all going to lead to a risk of fractures in elderly individuals. Normal spongy bone and then osteoporosis in the spongy bone. Here you see compressed lumbar fracture. Again, that's just because of decreased ossification, weakening of bones, weakening of connective tissue. Your bones are just going to be more brittle with age. You can pause the video here, go back and answer these questions. Let's talk about ball and socket joints, like our glenohumeral joint, aka shoulder joint. This is the greatest range of motion, so it is also our weakest joint in the body. Most frequently dislocated because it is so modal. It's a ball and socket diarthrosis You have the head of the humerus and the glenoid cavity of the scapula, which is where it fits. There are 5 major ligaments that surround the muscles and the tendons, and there are bursa here as well to reduce friction. The ligaments, you need to know them, but again, once you know the bones, you know the ligaments. Corticoclavicular, where is it from? The coracoid process and the clavicle. Acromioclavicular, acromial process and the clavicle. Coracoacromial, coracohumeral, glenohumeral. They're all just named after where they connect. Here you see them. You have the corticoclavicular, acromioclavicular, coracoacromial, you have your glenohumeral, coracohumeral, again, all named after where they're located. The bursa in there, wrapping around everything, making sure there's no friction. In fact, when you, see if I can get it to do it again. No. I can hear it, but I don't think you can. It's not that loud this time. When you move your shoulder around, that's my good shoulder. When you move your shoulder around, when you hear that popping sound, sometimes some old people like me have, what you're usually hearing is that bursa kind of sliding and slipping around in there. Or maybe the bursa isn't there anymore, and it's actually the ligaments that are kind of gliding over each other, producing that kind of popping sound. Kind of creepy. So let's talk about some other features of the glenohumeral joint. There's the articular capsule that goes from the scapula to the anatomical neck of the humerus. That is what is allowing for that extensive range of motion. There's very little articular cartilage, and there's something called a glenoid labrum. The labrum is kind of like a big catcher's mitt inside of that cavity. It's extending the rim of the cavity, making it deeper and allowing for more surface area for more attachment. So that the glenoid area of the scapula is actually pretty small. I'm looking to see if it's, you can't really see that much. But our scapular bones here are not that big. So this labrum reaches out and extends the joint cavity a little bit, extends that articulating surface a little bit more. Again, kind of acting like a catcher's mitt. That's why catchers have bigger gloves than the rest of the team. Do they? No, outfielders do. I don't know. I haven't watched baseball in like 10 years. All right, here you see some of the bursa, again, some of the ligaments that are involved, and the synovial membrane, the whole articular joint capsule. There it is, the glenoid cavity, the labrum, which is nice and deep. A lot of people tear the labrum or damage their labrum. That can be another very detrimental injury. Here, it looks crazy. All right, you can see some muscles in this one. We're not getting to muscles just yet. Let's talk about the hip joint, another ball and socket joint, but this one's more sturdy because there's not that many degrees of movement. There's really like flexion, extension, adduction, abduction, a little bit of circumduction, a little bit of rotation. So the acetabular labrum is here again to deepen and increase the depth of that joint cavity, and there is synovial fluid in here, etc. Nice fat pad. The ligaments, same thing, named after where they go, what they're connecting. The only one that has a weird name that doesn't quite fit what it is or where it is the ligamentum teres. But all the other ones are pretty much straightforward. So just remember, ligamentum teres is the hip joint. Let's talk about the articular capsule. It goes from the lateral and inferior surfaces of the pelvic girdle, intertrochanteric line of the femur. It encloses the head and the neck of the femur, and there are 5 ligaments there. Here they are. Transverse acetabular ligament, and again, once you know the bones, you'll understand where these things are and what they do. Crosses that acetabular notch, filling the gap of the acetabulum. You also have the ligamentum teres, also called the ligament of the femoral head. We'll probably just call it the ligamentum teres. It's the only one of this joint that doesn't have a specific name to it. It attaches to the fovea capitis of the femur. Pubofemoral, iliofemoral, ischiofemoral ligaments. There they are. And the head of the femur fits securely into that acetabulum, and hip fractures, usually along the femoral neck or between the greater and lesser trochanters, are much more common than dislocations, unlike the shoulder, where there was more dislocations. You can pause the video, go back and review. Let's move on to the elbow joint. It's a complex hinge joint, humerus, radius, and ulna, 3 bones at our elbow joint. It's very stable because we have interlocking bones here. The humerus and ulna actually lock into each other. There's a very thick articular capsule with our humeral ulnar and radial ulnar joints. There's also lots of articular reinforcements, lots of strong ligaments in this area. Severe stresses can still produce dislocations, especially if there is no, if the growth hasn't finished on that epiphyseal growth plate. So nursemaid's elbow is a partial dislocation of the radial head. And to be honest, I don't know much about this, but I assume a nursemaid is someone that was maybe a young girl holding babies or doing something like that, helping nurses, and just extreme, movement, extreme working of that joint before it was done growing. All right, elbow joint, the humeral radial joint, the humeral ulnar joint. The humeral radial joint is between the capitulum of the humerus and the head of the radius, and the humeral ulnar joint is with the trochlear notch and the ulna. So this is a very strong articulation because that ulna has that notch in it that goes around that trochlea. The elbow joint has a proximal radial ulnar joint also that's not part of the elbow joint. This is where the humerus and ulna are basically held in position together. So it's not part of the articulation, but those 2 bones are held together also. There's muscles in there as well. The tendon of the biceps brachii is an important one. That's really the only big one there. That's providing that leverage for flexion. Here you see the actual bones articulating. Posterior view, you can really see that olecranon process on the ulna fitting into and around that trochlear notch, trochlea, and then the radius going around the capitulum. So the elbow joint has ligaments as well, and just like before, they're pretty much named after what they do, except the annular ligament, which is another kind of weird one. So you have your radial collateral ligament and your ulnar collateral ligament. They're just going around lateral and medial sides, and then the annular ligament is connecting the 2 bones together, connecting the radius and ulna together, kind of wraps around. Think annual, like a year. Takes a year for the earth to go around the sun, so the annular ligament goes around the radial and ulnar joints. There you see them. Knee joint, which we kind of talked about already in terms of just the general features, but since we're talking about hinge joints, we may as well throw it in there. It contains 3 separate articulations between the femur and tibia, 2 between the femur and tibia, and 1 between the patella and the patellar surface of the femur. So there's 3 things going on. You have the lateral condyle of the tibia, lateral condyle of the femur, medial condyle of the tibia, medial condyle of the femur, and the patella and patellar surface. They permit flexion, extension, very limited rotation. You know what happens if you rotate at the knee joint, right? That's that ACL snapping. The fibula is not part of the knee joint, as I said before. So some supporting structures, we mentioned the quadriceps tendon passing over that anterior surface of the patella, goes into and continues as the patellar ligament going all the way down to the anterior tibial surface. You have the fibular collateral or lateral collateral, however you want to remember it. I usually call it the fibular collateral ligament. That way I remember it's on the fibular side. And the tibial collateral ligament. Fibula is lateral. Tibia is medial. So just the fibula has an L in it, which is lateral. Tibial collateral ligament or medial collateral ligament is for medial support. There they are. And again, these diagrams are also on your Lab Practical 2 review sheet, so make sure that you get to know and love them. Let's talk about the popliteal ligaments. These are running between the femur and the heads of the tibia and fibula. These are on the posterior surface, hence popliteal, back of the knee. There is that view. You can see the popliteal ligaments. You can see a little bit of the tibiocollateral and fibular collateral ligaments. There's also medial and lateral meniscus. These are those fibrocartilage pads between the femoral and tibial surfaces. They're cushioning and acting as support. There you can see them stuck right in there. And again, they fit in like a puzzle piece. They're nestled in there very nicely. You also have your cruciate ligaments. These limit anterior and posterior movements of the tibia. So basically helping the tibia stay in line with the femur so that there's none of this going on, holding it in place. You have your ACL, anterior cruciate ligament. This is at full extension. It's basically forcing the lateral meniscus in between the tibia and the femur. It basically locks that knee into extended position. And then the PCL, or posterior cruciate ligament. Here you can see your PCL and your ACL. This is a posterior view. And you can pause here, go back and answer these questions. We're going to get a little bit into clinical terms here. Rheumatism, that's just that general aching and stiffness. As you get older, when you wake up in the morning, you're like, ah. At least I am, and I'm not even that old, but it happens. And that's just, it's called rheumatism, the general term for pain and stiffness. Arthritis can be of different types. It can be osteoarthritis, it can be rheumatoid arthritis, or it can be gouty arthritis. So let's talk about osteoarthritis first. Osteoarthritis is a degenerative disease. So this is the most common form of arthritis. This is typically just caused by wear and tear. You're a marathon runner, so eventually your knees are going to be bad, right? Or you're a golfer, so eventually your shoulders are going to be bad, right? Whatever joint you're overusing is going to just suffer some wear and tear. Typically it's 16 older, but depending on how active you are, you could show signs as early as 20 or 25. There is osteoarthritis, inflammation of the joints. They're just inflamed because they're wearing away. Those articular cartilages just aren't there. So in normal changes, joint changes with arthritis, typically you have that smooth, slick surface, but in osteoarthritis, you're going to have maybe bristly, worn away collagen fibers. That's going to increase friction at the joints. That's going to promote further degeneration. That's going to promote inflammation, etc. Pain, all of the above. So here you can see the articular cartilage in a normal, healthy joint. Looks nice and fresh, and then in an arthritic joint, it's definitely starting to wear away, and that fibrous cartilage is fraying at the end, so to speak. So clinicians can use an arthroscope, which is a tube with a tiny camera at the end, optical fibers, kind of look around and check out what is going on with your joint cavity. It's called arthroscopic surgery when they're using instruments to go in and repair something with that little camera. There it is, arthroscopic view of the knee. You can see the PCL, the meniscus. And if you took those labels away, you look at it and an untrained eye, myself included, would not really know what I'm looking at. This is why doctors go to medical school and surgeons take years and years and years to perfect their craft, because looking at just that one little view, it's very hard to know exactly what you're looking at. There are other ways of visualizing these problematic joints other than going in with a little camera. You can use an MRI. This is going to allow you to see the soft tissue outside of the joint. It's very cost effective. It's non-invasive. You just stick your joint into that little tunnel and check it out. Of course, it uses magnetic resonance imaging, which is why it's called an MRI. So if you have metal in your body, you can't get an MRI. This is just an overview of the knee. This is a little bit more distinguishable than that arthroscopic view. So here you can see the condyles, you can see the PCL, you can see the patella. This is a nice cross-section. You can see kind of where the different parts are, tibia, fibula here, some of the muscles. Again, it allows you to see those soft tissues very well. Artificial joints are usually the last resort for arthritis treatment. Typically, what they'll suggest for arthritis is regular exercise, anti-inflammatory drugs, physical therapy even. But artificial joints can restore motility as well as relieve pain. High-impact activities are usually restricted, and new joints and hips and knees and such can last usually around 15 to 20 years, which is why if you are an uber athlete and you damage your knees or shoulders or something in a very young age, they're not going to do a joint replacement on a 25-year-old because the joints are only designed to last 15 years and you're going to live more than 15 years. So they usually wait until later in life for that. The devices that they use for these artificial joints are really cool. They're getting lighter and lighter. They used to be made of like really heavy, I forget the name of the metal, it was so heavy. So people that had these artificial joints, you know, back in the 60s and 70s, these were very like archaic looking structures, and now they're very modern, they're light, less chance of infection, etc. So go ahead and pause the video. Actually, you don't even have to pause it. This is the end. You can stop the video, answer these questions, and let me know what questions you have about articulations, about joints. All right, have an awesome day, and I will talk to you guys later. Bye.